Hello, everyone. My name is Danielle Dunster, and my research proposal presentation is going to be about comparing fidelity-based motivational interviewing and cognitive behavioral therapy on treatment engagement among adult males with methamphetamine use disorder in outpatient recovery. And I know that sounds like a lot, but I'm going to explain. So let's keep going. So the introduction that I have for you today is to let you know what the problem is that my study was focusing on. And that is that methamphetamine use is increasing in the United States. Most outpatient programs are struggling with keeping patients engaged and coming. Clients are often experiencing additional trauma, mental health concerns, returns to use, and instability. And the treatment engagement is really connected to positive recovery outcomes. So, my research question is, does fidelity-based motivational interviewing improve this engagement more than CBT, which is cognitive behavioral therapy? The population for the study is adult males ages 18 through 65 in Broome County, New York, who are diagnosed with MUD and in outpatient treatment. MUD being methamphetamine use disorder. The hypothesis is participants receiving this fidelity-based motivational interviewing will show stronger engagement in treatment than those who are only receiving CBT. During my literature review, this is what I found. Research supports that both motivational interviewing and cognitive behavioral therapy as evidence-based interventions are successful. MI improves motivation and early treatment engagement, where CBT supports coping skills and relapse prevention. The studies emphasized having fidelity-based implementation and training. And what this means is that they were both more successful if the people that were the clinicians in these settings were trained appropriately. The literature also suggested a need for a direct comparison of MI and CBT that focused on only engagement, not retention, etc. So, what I found overall was that the research really supported using both motivational interviewing and cognitive behavioral therapy in conjunction, that one wasn't necessarily better than another one. So, the theoretical framework for the study is person centered theory developed by Carl Rogers. That's what primarily guided this study. Obviously, using motivational theory, which explains readiness for behavioral change, and cognitive behavioral therapy, which focuses on your thoughts, emotions, and behaviors. And of course, the study aligned with trauma informed social work practice. My methodology, this was a mixed methods approach study. The quantitative quasi-experimental design basically looked at treatment engagement percentages between the groups, between the MI group and the CBT group. And the qualitative design really was looking for reoccurring themes related to treatment experiences and, in regards to engagement. So really looking at the responses from both groups. And this, of course, was done in a real life outpatient setting. This was a purposive sampling method, and that participants were recruited from outpatient programs in Broome County, New York. They were only adult males ages 18 to 65 with methamphetamine use disorder, and the estimated sample size was 40 to 60 participants. So, participants were recruited through these outpatient treatment programs because they were readily available. Of course, informed consent and confidentiality were key components. The study period was approximately 8 to 12 weeks. So the attendance, participation, and retention were all tracked. And of course, that qualitative component was the open-ended survey that was completed by the participants at the end. So how we measure this, attendance percentages were measured. So you looked at the MI group and what percentage attended, and the CBT group, same thing. Um, so the participation really was, and the retention rates were compared between the two groups. The qualitative themes, really through thematic analysis, really what we're looking for there is like those repeating patterns of ideas, responses, in result to that open-ended survey. And then the effectiveness was measured throughout treatment engagement outcomes. And what I found was quite a few limitations. Purposive sampling really limited my generalizability. Obviously, it excluded women, um, inpatient participants, people that were in residential treatment, and people with other substances involved, people that are using other substances such as alcohol and marijuana. So, this quasi experimental design could possibly create some selection bias. And what this means is maybe one of those groups had people in it that were already leaning towards recovery, where the other group had a lot of people that were leaning more towards a return to use. So there could be bias in the groups as far as that selection process. Um, the self-report surveys also could like really affect reliability in that some people may not tell the truth in fear of like stigma or repercussions or even legal matters. And then lastly, for limitations, really the differences in how the clinicians are trained, what their fidelities and skills look like, that can definitely impact the results. If you have someone who is truly trained in fidelity-based motivational interviewing, and then someone who really isn't trained in cognitive behavioral therapy, and one of them is running each of these groups, that could definitely impact the results. So really, in conclusion, I think the thing that I took away was that evidence-based practice in outpatient recovery settings is crucial, and that really using motivational interviewing and cognitive behavioral therapy in conjunction with clinicians that are trained, that are fidelity based, could improve engagement and recovery outcomes. So I really feel that this study could really help improve these outcomes for the population, and really strengthen the use of fidelity based training, not just in MI, but also in CBT. Thank you so much for listening today, and I appreciate your time.